Assalamu alaikum and very good evening to all. Welcome you all to today's session on water and electrolyte imbalance. To tell us about it, we have excellent two speakers from National Heart Foundation Hospital and Research Institute, Dr. Dhiman Bonik, Associate Professor of Cardiology, and Dr. Abida Tasnim Reza, Registrar Cardiology. We also have with us Associate Professor Dr. Tanzima Parvin from the she will give her expert opinion from examiner's perspective. Among others, expert panelists.
Ishraq, you're muted. Ishraq, you need to. Now it's fine. Thank you.
Okay.
Accidentally, you muted yourself, maybe.
So I'll request Professor Fazila Malik Madam to tell something before we start the session.
So thank you everyone who have joined us today. This is going to be a very interesting session, I believe, because in many instances in our hospital, we have patients that we have to give diuretics or who come to us, maybe they're in a confused state and we do their electrolytes and we see that there is some electrolyte imbalance. So these are situations that we face day to day in our clinical practice. And we have to learn about these things because our knowledge, I feel, in many instances is a bit lacking. So I'm so grateful that we'll be having this session today. And I'm really grateful that we have with us a great teacher, Tanzima, who's going to help us, help our students to learn what is important about this very interesting subject. So without further ado, I would request Ishraq to conduct the session. Thank you, Dr. Ishraq.
Thank you, Madam. So now I'm going to request Dr. Dhiman Bonik, Associate Professor of Cardiology, to share his screen and sir. So are you ready?
Yes, I am ready.
Okay, sir. Please carry on, sir. Thank you.
Screen is shared? Yes.
Yes, sir.
Okay, today the topic is water and electrolyte imbalance. I will be talking about water imbalance, and my next co-speaker, Dr. Abida, will be speaking on electrolyte imbalance. From the very beginning, about the total body water. Total body water depends on the age, sex, and body weight. It seems that in a newborn infants, around 90 to 95% of the body weight, body water is body weight of the 90 to 95% of the total body weight is the body water. In the children, it is about 75 to 80%. In an adult male, it is 60%. In female, the total body water is about 5 to 10% than that of the male of the same sex. It is due to the more fat containing in the female. Total body water is about 72% of the lean body mass. Lean body mass is fat-free body tissue. It means fat-free body tissue. Brain contains, in our body tissue, brain contains highest amount of water. It is around 84%. And adipose tissue contains the least amount of water. It is 10%. Regarding the body fluid compartments, the intercellular compartment, the fluid in the intercellular compartment is the intercellular fluid. In the extracellular compartment, the fluid is the extracellular fluid. The intercellular compartment or the interstitial space, it is the interstitial fluid, and in the intravascular space, it is the plasma. So these are the body fluids which will be we are discussing about. Total body water distribution is a adult 70 kg adult male, around 60% of the total body weight is total body water. It is around 42 ml. The intercellular fluid is the 2/3 of the total body weight. It is about 28 liter, and the extracellular fluid is the 1/3 of the body weight. It is 14 liter. In the extracellular fluid, there are two important fluids are there. That is plasma and interstitial fluid. It is about 3 liter plasma, and interstitial fluid is around 11 liter. The interstitial fluid contains two special type of fluid, which is the lymph, which is very important. It is 1.5 liter, and transcellular fluid. The blood tissue is a summation of intercellular and the extracellular fluid. RBC is the component of the intracellular fluid, and plasma is the component of the extracellular fluid. This is an important slide showing the ionic composition of the body fluid. Ionic composition in extracellular and intracellular fluid, you can see that the total cations and anions in the extracellular fluid should be equal. It is always equal. The cations is 150 milliequivalent or millimole per liter, and the anion is 150 millimole. In the extracellular fluid, mainly cations is sodium at an average of 135 to 145 millimole per liter, and the main anion of the extracellular fluid is chloride ion. It is around 98 to 107 millimole per liter. In the intercellular fluid, the cations are around 200 millimole or milliequivalent, and the anion is also 200. It is the same to maintain the equilibrium. And in the intercellular fluid, potassium is the main cation, and the phosphate is the main anion. There is a law of electrical neutrality which states that in a living system, every body fluid compartment is electrically neutral, containing the same amount of positive charges, that is the cation, and the negative charges, that is the anion. I have already mentioned it in the previous slide. These are the functions of the body water: maintaining the metabolic integrity, transport of different substances from the intercellular space to the extracellular space, maintaining of the circulatory integrity. Body fluid osmolarity is maintained by the body fluid, and thermoregulation, and it maintains the form and the texture of the tissue. There is a osmotic equilibrium in all the body fluids of the body. It is the osmotic pressure of the intracellular fluid, extracellular fluid, interstitial fluid, and plasma are identical, which is about 280 to 300 milliosmol per liter. I have already mentioned that main osmolarity of the extracellular fluid is maintained by sodium chloride, and of the intercellular fluid, main osmolarity is the potassium. Practically, plasma osmotic pressure is the direct function of the plasma sodium concentration. What is the what will happen when there is disequilibrium between the intercellular fluid and an extracellular fluid? When the extracellular fluid osmotic pressure is less than the intercellular fluid osmotic pressure, that is, if there is infusion of an hypotonic solution, then the intercellular fluid osmotic pressure will be more than that of the extracellular osmotic pressure. Then there will be a cellular overhydration due to the water enter into the cells, and there will be increased intercellular hydrostatic pressure, and the cell impairment of cellular metabolic activities, and there will be cerebral edema leading to coma. When there is cerebral edema, this is the mechanism of death in patient with disequilibrium of the extracellular fluid and intercellular fluid. That is, rest intracranial pressure will be there. Brain will be pushed caudally, and there will be herniation of the brain through the foramen magnum, and there will be venous of outflow tract obstruction of the brain, and there will be brain damage and death. These are the important consequence of the disequilibrium of rising of intercellular fluid osmotic pressure than that of the extracellular fluid osmotic pressure. When the extracellular fluid osmotic pressure will be raised, then that of the intercellular fluid osmotic pressure. That is, a commonest example is that very high infusion of an hypertonic solution. There will be cellular dehydration will be there due to water loss from the cell, impairment of the cellular metabolic activity, potassium efflux of the cell leading to hyperkalemia, and there will be cerebral dehydration. Due to cerebral dehydration, there will be neuronal squeeze and stretching of the blood vessel and the inner surface of the brain. There will be a rupture of the blood vessel leading to intracerebral or subretinal hemorrhage, leading to coma or death. These are the important consequences of disequilibrium between the extracellular and intracellular fluid. This is the I have made this slide to show some fundamental tips about the body fluid compartment. Water is confined to a when water is confined to a particular body compartment, or water loss or due to water loss, it will be shared among all the compartments of the body. So not a single compartment will be hampered, all the compartment will be hampered. Water loss, loss of intercellular fluid causes cellular dysfunction, that is lethargy, confusion and coma. These are the important symptoms when there is loss of intercellular fluid. And when there is loss of extracellular fluid, we'll clinically find the patient is dehydrated. When there is blood loss, it causes circulatory collapse, renal shutdown and shock. These are the important three clinical factors due to loss of the fluid in different spaces of the body. These are the important examples of hypertonic fluids. It is a very important slide for all of us. 3% normal saline we commonly use in severe form of hyponatremia. It is a hypertonic solution. 10% dextrose in water, 5% normal saline, that is we commonly termed as 5% DNS, 5% half strength normal saline. It is 5% dextrose with 0.45% of saline and 5% dextrose. These are the hypertonic fluids. This is a slide of the hypotonic fluids. These hypotonic fluids are commonly used in the neonatal ICU or CCU. It is 0.45% of half strength sodium chloride solution and 1/3% sodium chloride solution, 0.2% of sodium chloride solution, and 2.5% of dextrose. Hypotonic fluids should be used cautiously during hypervolemia or hypovolemia or in patients with CCU or ICU. These are the important example of the isotonic fluids. Normal saline, 0.9% normal saline, we commonly used it. It is the isotonic solution. Ringer's lactated solution is an isotonic. 5% dextrose water is also an isotonic solution. These are the biochemical consequences of an intravenous body fluid infusion. When we infuse hypertonic solution, that is, for an example, 5% DNS, then the extracellular fluid osmotic pressure will be raised, intracellular fluid osmotic pressure will be raised, the plasma concentration of sodium will be increased, and there will be sodium contents of the body will be increased. If we use hypotonic, then hypotonic solution, then all the osmolarity will be decreased in extracellular fluid and in the intercellular fluid, and there will be hyponatremia also in the body fluids. And isotonic solution maintains the osmolarity of the body, extracellular fluid, intercellular fluid, and the sodium concentration will be normal. This is then another slide showing that the composition of osmolarity and sodium and chloride of different importance infusion saline. In normal saline, the sodium is around 154 millimole. It is important for the equation of maintaining hyponatremia. In 3% normal saline, we commonly used it. It is the sodium chloride is around 513 millimole. And in the Ringer's lactate solution or Hartmann's solution, the osmolarity is 273 and sodium is 130 and chloride is 109. We commonly use another solution. It is the colloidal solution. Albumin solution are available in 5% and 25% of albumin. These are the colloidal solution, dextran solution, and Hitastar solution. We commonly use a body fluid which is known as Hemaxil. It is a Hitastar solution. It is a colloidal solution. When we use a colloid solution, it increases the colloidal osmotic pressure of the plasma, and this fluid results in the extracellular space to move into the intercellular space, and there is increase in plasma volume to maintain the normal cardiovascular health. in hypovolemia due to major surgery after hemorrhage. We commonly use Himaxil, I have already mentioned, and this is the colloidal solution. Now comes the water balance of the body. Water balance is maintained by intake and output. Intake is obligatory intake by drinks is around 650 ml, and facultative intake is about 1000. And from the body water and metabolic water, after metabolism of the carbohydrate, proteins, and fat, around 400 ml of fluid is secreted in our body. It is about intake is about 1600 to 260 ml per day, and the body loss of the body from the body by urine it is around 500 to 1000, by via skin which is known as perspiration, and via expiration which is known as transpiration, and it is about 900 to 1000. Through stool it is around 150 ml. So total body output, total body loss commonly is around 1600 to 260 ml per day. It is important in our maintaining the intake output chart of a critical patient in CCU and ICU. Then how the body water balance is regulated, that is which is known as osmoregulation. It ensures that osmoregulation is mainly maintained by ADH and the thirst mechanism. ADH regulates water balance by regulating the renal free water excretion or retention. ADH secretion is stimulated by plasma hyperosmolarity and hypovolemia, and thirst is also is a mechanism by osmoreceptors, which are also stimulated by plasma osmolarity and hypovolemia. It is important to mention that hypovolemia is less sensitive stimulus than hyperosmolarity to regulate the thirst and ADH release. That is, if the osmolarity is raised by 1 to 3%, it is enough to stimulate the ADH secretion and the osmoreceptor to cause a thrust, whereas about extracellular fluid volume reduction is about more than 10 to 15%. So osmolarity is a more sensitive substance to stimulate the ADH and osmoreceptors. This is an important flow chart of when there is water deficit or negative water balance in the body, how the compensatory mechanism comes into play. During water deficit or there is negative balance in the body, there is increase in extracellular fluid osmotic pressure, that is fluid is hyperosmolar, and there is osmoreceptor stimulation, and on the other hand there it is the state of hypovolemia, there is water state, and their baroreceptor is inhibited, and sympathetic nervous system is stimulated, and renin angiotensin aldosterone system is activated, and there is, we all know this is the increased secretion of renin, and there is increased angiotensin 2. This all causes increased thrust and increase in ADH secretion, and increase of water intake and renal water retention. So there is restoration of the extracellular fluid osmotic pressure. This is the compensatory mechanism of water deficit in our body. The hypernatremia and hyperosmolarity will be mentioned by my next speaker, and it is there is an important term that it is what is water intoxication. When water intake is more than maximum renal water excretion, it results from water moves into the cell by osmosis, leading to cerebral edema, causes coma or death, which I have previously mentioned. Water intoxication is a common phenomenon in cases of advanced stages of CRF. There is an important term which is known as insensible water loss. I've already mentioned it is by skin, it is around 550 ml. By expiration, it is around 400 ml. It importantly depends upon body surface area and respiration and temperature and atmospheric temperature. Metabolic water, I've already mentioned, there is metabolic water. This is an insensible water gain into the body by oxidation of the carbohydrate, protein, and fat. What is the obligatory water loss? Obligatory water loss is about 1500 ml per day. It consists of obligatory urine volume around 500 ml and insensible water loss around 1000 ml. A minimum exogenous water intake, it is the obligatory water loss minus the metabolic water. It is around 100 ml per day. Survival is not possible with 20% of the, if there is not 20% of total body water. Total body water is about 42 ml, so around 20% is 8.4 ml. So 8.4 ml divided by the obligatory body water loss is 1.5 ml. So survival without water is possible only for less than 6 days, only for less than 1 week or even. This is the classification of the volume disorder. Hypovolemia is defined as the reduction of circulatory blood volume. Hypovolemia important causes are from GI if there is vomiting, diarrhea, or intestinal obstruction or peritonitis. Renal causes are importantly salt and water loss, use of diuretics, renal tubular necrosis, nephrogenic diabetes insipidus. Cranial diabetes insipidus is an important CNS cause of hypovolemia, and other causes are bleeding, sepsis, shock, and burns. The important clinical features of hypovolemia and hypervolemia, I have put it in the same slide. The symptoms of hypovolemia are thirst, dizziness on standing, and weakness. Postural hypotension, there is tachycardia due to increased sympathetic drive, dryness of the mouth, skin turgor is decreased, reduced urine output, weight loss, and delirium and stupor due to cerebral involvement. And hypervolemia, when there is hypervolemia, there will be ankle swelling, abdominal swelling, or breathlessness will be there. There will be features of pulmonary edema, neck vein will be raised, there will be crepitation in the lung, pleural effusion will be present, ascites, weight gain, and there will be occasional hypertension. Hypovolemia is of 3 types. It is if there is an isotonic hypovolemia, hypertonic hypovolemia, or hypotonic hypovolemia. Isotonic hypovolemia is loss of both sodium and water from the extracellular fluid in equal amounts. Common examples are through poor intake of the body fluid, vomiting or diarrhea, if there is small intestinal fistula, ileostomy, polyuric phase of chronic renal failure, and in intestinal obstruction. No osmotic shift from intercellular to the extracellular fluid is present. Hypertonic hypovolemia is when the loss exceeds the sodium loss. That is, water loss is exceeds by the sodium loss is more than the water loss. It is characterized by osmotic shift of the water from the intercellular fluid to the extracellular fluid. Commonest example are severe diarrhea, profuse sweating, severe burn, osmotic diuresis in different nephritis, salt-losing nephritis, and persistent vomiting or nasogastric suction. Hypotonic hypovolemia is clinically rare. A condition may give rise to hypotonic hypovolemia, that is excessive infusion of normal saline. Investigations to be done in case of hypovolemia is serum electrolytes will give our views for the sodium and potassium and chloride and bicarbonate. Doing and creatinine will give rise the functions of kidney. Blood urea concentration is typically elevated due to low urine flow, which is accompanied by increased tubular reabsorption of urea, and urinary osmolarity may be done, which will increases due to increased reabsorption of sodium and water. Management of hypovolemia is to stop the ongoing salt and water loss. It is very important to treat the cause, replace this salt and water deficit, and provide ongoing maintenance of requirement of the IV fluid replacement, and depletion is very severe. Hypotonic solution should be avoided in this hypovolemic state, as these worsen sodium hemostasis and do not stay longer in the extracellular fluid, worsening edema. Hypertonic solution is reserved for the treatment of cerebral edema. The important intravenous body fluid therapy is water requirement of a 70 kg adult man in an adult is around 2.4 ml to 3.15 liter per 24 hours. Sodium requirements is 105 to 140, and potassium is around 170 to 150 ml. This is the normal sodium, potassium, and water regular requirement of our body. This is the slide. It is the slide of how to assess a patient in CCU or ICU with a patient with hypovolemia or hypervolemia. They examine the signs of hypovolemia and hypervolemia, check the weight change of the body, maintain the input and output chart of the body, check the cumulative fluid balance with the previous 3 to 5 days. And if there is any loss, ongoing pathological process, or there is any loss due to loss from the GI tract or from the surgical drains or from insensible loss, and 3 or 4 important things should be checked. Sodium should be checked regularly as a marker for relative water balance, and potassium as a guide of extracellular potassium balance, and bicarbonate is an important clue for acid-base disorder, and check urea and creatinine to monitor the renal function. Replace the water and electrolyte each day, and this will be talked by my next speaker. Allow oral intake of pathological fluid loss, and adjust the amount of fluid. If IV, usually give as isotonic DA and sodium potassium according to the requirement. The hypervolemia is defined as the increase in the circulatory blood volume, and it is also divided in the 3 states: hypotonic hypervolemia, isotonic hypervolemia, and hypertonic hypervolemia. If use of hypotonic hypervolemia is increased antidiuretic hormone activity, liver failure causes hypotonic hypervolemia, and isotonic hypervolemia is commonly found in heart failure patient and with renal disease patient. Hypertonic hypervolemia is an iatrogenic condition, most commonly iatrogenic administration of hypertonic solution. In Cone syndrome or Cushing syndrome, there is hypertonic hypervolemia, or in patients with steroid abuse. These are the again the investigation, important investigation to be done and to be evaluated is electrolytes, creatinine, and the important investigation for cardiac and renal and liver disease. And management should be in the following headings: strictly fluid intake, strict fluid intake, restriction of fluid intake should be maintained, and in patients with heart failure, ACE inhibitor should be used. In patients with minimal change nephropathy or severe forms of nephropathy, glucocorticoids may be used. Sodium restriction should be up to 50 to 80 millimole per in 24 hours, and judicious use of diuretics. This is all known to our speakers, panelists, and everyone of the attendants. I just recapitulate these things, and I am thank you all for patient sharing.
Okay, thank you, sir. Thank you. So now we are moving to our next topic, electrolyte imbalance. After that, we'll have open discussion. So Dr. Abida, so are you ready? Dr. Abida?
Yes, I'm opening.
Okay, okay, floor is yours.
Honorable Chairperson, respected panelists, and dear learned audience, Assalamu alaikum and a very good afternoon. I'm Dr. Abida Tasnim Reza, Registrar, National Heart Foundation Hospital and Research Institute. Welcome you all on my presentation on electrolyte imbalance. Today, I'm going to discuss about hypohypernatremia and hyperkalemia and electrolyte imbalance, which are very, very important in our day-to-day clinical cardiological practice. But the treatment and management are not as simple as that. So now my previous esteemed speaker has already mentioned a lot about sodium and potassium and extracellular and intracellular fluid. So sodium homeostasis, why it is very, very important? Because sodium is the major cation in the extracellular fluid, and it is the sodium that maintains the cellular integrity. And in cellular level, it is a sodium-potassium pump which actively participates in all intracellular activity.
Dr.
Abida, your
sorry
slide
to,
is.
yeah, sorry to interrupt you. We cannot see your slides. So would you?
Okay, I'm again sharing. Okay.
Yeah, please.
Now, can you see?
Yes, yes, now
Yes,
on.
yes, now it's fine.
Yes,
Okay, should I start from the beginning?
yes.
Okay. Sorry for the interruption. Honorable Chairperson, respected panelists, and dear learned audience, Assalamu alaikum and a very good afternoon. I'm Dr. Abida Tasnim Reza, Registrar, National Heart Foundation Hospital and Research Institute. Welcome you all on my presentation on electrolyte imbalance. So electrolyte imbalance, I'm going to discuss on hyponatremia and hyperkalemia, which are very, very important in our day-to-day cardiologic practice. And the management is not as simple. So as my previous esteemed speaker has already mentioned, sodium is the major cation that is in the extracellular fluid, and it is a sodium potassium pump in the intracellular level that maintains all the cellular activity and also all the cellular activity. It is the kidney that maintains the sodium balance in the body by constant reabsorption of sodium in various levels. So sodium homeostasis is important because it maintains the extracellular fluid volume, and it is the renal angiotensin aldosterone system activation along with baroreceptors, sympathetic nervous system, the pressure receptors and volume receptors that maintains all the sodium balance in the body. So the normal plasma sodium is 135 to 145 millimole per liter, and normal plasma osmotic pressure is 280 to 300 milliosmol per liter. And it is sodium that maintains 92% of body osmotic pressure. So it is very, very important. So plasma sodium less than 135 millimole per liter is defined as hyponatremia, and most of the time it is the water that may causes this hyponatremia rather than the loss of sodium. So we move on to the types of hyponatremia. The hyponatremia is divided dependent on the plasma osmotic pressure as isotonic, hypertonic, and hypotonic hyponatremia. What do we mean by isotonic hyponatremia? Here, the plasma osmolality and total body sodium is normal and patient is clinically euvolemic, which is actually seen in also known as pseudo hyponatremia or artifactual cause when there is high serum lipid or protein or blood glucose. This results in this kind of hyponatremia. Blood sample taking from a drip arm is a common mistake that may result in isotonic hyponatremia. Now, what is hypertonic hyponatremia? Which implies plasma osmolality is increased, but total sodium is normal. Patient is again euvolemic, and hypertonic hyponatremia is commonly found in acute kidney injury and uncontrolled diabetes patient. Now we move on to hypotonic hyponatremia. Here, the plasma osmolarity is low, and the patient may be hypervolemic, hypovolemic, and euvolemic. So here in hypervolemic hyponatremia, what happens is the total body sodium and extracellular fluid volume are both increased, but the increase of sodium is less than that of the ECF volume. Here, there will be presence of edema. What we find is in congestive cardiac failure, cirrhosis, and nephrotic syndrome patient, mainly hypervolemic type of hyponatremia. Now, the hypovolemic type of hyponatremia. Here, both the total sodium and extracellular fluid volume are decreased. That is, the extracellular fluid volume is more decreased than that of the sodium. So as a result, what happens is dehydration is present. And the dehydration can be due to renal losses of sodium, such as diuretic therapy, gastrointestinal sodium losses, such as vomiting diarrhea, and skin losses, such as burns. So after that, the euvolemic hyponatremia. Here, both the total sodium and extracellular volume are normal, and patient is clinically euvolemic. Mainly what happens is there is increased intake of water that is occur in primary polydipsia or water infusion with excessive electrolyte free. Syndrome of inappropriate ADH secretion is also one of the cause, along with hypothyroidism. Now, Hyponatremia can again be classified in another classification depending on rapidity of development of hyponatremia. If it develops within 48 hours, that is less than 2 days, it is acute hyponatremia. And if it takes more than 48 hours to develop, it is classified as chronic. Here in this picture, we can see that if there is chronic development of hyponatremia, there is adaptation of the cerebral cells. As a result, there is normal cerebral cell size. But what happens if there is abrupt fall of hyponatremia? This results in decreased plasma osmolality, resulting in cerebral swelling and cerebral edema and the manifestations we find. Now, depending on the laboratory findings, we again can classify hyponatremia into mild, moderate, and severe, where mild is 130 to 135, moderate is 125 to 129, and severe is less than or equal to 125 more millimole per liter. The clinical manifestation specifically in more than 130 to 135, usually none. Most of the cases, the manifestation of clinical symptoms are neurological. If it is 125 to 129, there will be nausea, delirium, headache. And if it goes unchecked, that is less than 124 or severe hyponatremia, there will be vomiting, somnolence, seizures, coma, and ultimately cardiorespiratory arrest. So cardiac symptoms may occur if there is less than 100 millimole per liter of sodium. Now, the diagnosis, we can see the features, history of dehydration symptoms or overhydration symptoms. Physical examination may reveal the volume status of the patient. How can we diagnose the hyponatremia? 3 investigations are extremely important. That is plasma osmolality, urinary osmolality, and urinary sodium excretion. So here is an equation which showing the plasma osmolality that can be calculated very easily if we know the value of glucose and blood urea nitrogen. Now, what is the diagnostic algorithm of hyponatremia? We can combine it like that. If there is hyponatremia in lab investigation, we should check urea, glucose, lipids, and immunoglobulins. If these are abnormal, then we can classify it as pseudo-hyponatremia. But if these are normal, then we can categorize it as hypoosmolar, that is plasma osmolarity is decreased. Then we go for checking the urinary osmolality. If it is less than 100 milliosmol per kg, that is urine is diluted. It means there is excessive water intake and we can diagnose the patient has primary polydipsia. But if urinary osmolality is increased, that is more than 100 milliosmol per kg, we should go. Next investigation will be measurement of urinary sodium. So urinary sodium, if it is less than 30 millimole per liter, it indicates there is low intravascular volume. So we should check for signs of volume depletion or volume overload. Now, what happens if urinary sodium is more than 30 millimole per liter? Then we have to diagnose whether there is any kidney disease. If there is kidney disease, then we can say this hyponatremia is due to kidney disease. But if it is not, then we go for volume status. If there is hypovolemia, then we should search for whether there is any diuretics overdose or adrenal insufficiency. If extracellular fluid volume is within normal limit, then CIAT or hypothyroidism should be diagnosed. So this is a diagnostic algorithm. How can we treat hyponatremia? So goals of treatment will be to raise plasma sodium by restricting water intake and promoting water loss, and of course to correct the underlying disorder. In case of hypovolemic patient, we should go for isotonic solution or 3% NaCl or hypertonic saline solution. And water restriction is more than enough in euvolemic and hypervolemic patient. Other treatment like tolvaptan oral urea has been recommended in euvolemic cases. So when should we treat hyponatremia? If the patient is symptomatic along with plasma sodium less than 120 millimole per liter. If the patient is asymptomatic, the treatment should be like that, 0.5 to 1 millimole per liter per hour and 10 to 12 millimole per liter over first 24 hours. If the hyponatremia is less than 110 milliequivalent per liter, then we should start 3% NaCl in 1 to 2 millimole per liter per hour for the first 3 to 4 hours. And it should never exceed 12 millimole per liter in 24 hours and should never be given more than 700 ml per day. How to calculate the sodium deficit? There is a calculation where we can calculate the sodium deficit with total body water and the present sodium. So total body weight can be calculated from body weight, and males and females have other variants. So change in plasma sodium can be calculated by these equation, such as, let's see a case scenario: a 45-year male, 50 kg by weight, presenting with altered sensorium agitation, and we diagnose that patient has hypoosmolar hyponatremia. So plasma sodium is 110 millimole per liter. So how can we calculate to correct hyponatremia of this patient? Sodium requirement first will be calculated by the formula mentioned. So in this patient, it will be 600 millimole. So 600 millimole should be the sodium deficit. So change in sodium, as we want to give 3% NaCl, it contains 513 millimole of sodium. So we can calculate it is 13 millimole per liter. So in 100 ml, there will be 1.3 millimole per liter. So in total, the patient will require 100 ml over 24 hours, and the rate will be 34 ml per hour in syringe pump. But it is very, very important not to correct this hyponatremia rapidly, because it may cause central pontine myelinosis, chronic hyponatremia, flaccid paralysis, dysarthria, dysphagia, and it has no specific treatment. So when the patient goes to the normal level of sodium, we can give oral sodium chloride tablet or oral supplementation. Now we move on to hypernatremia. In hypernatremia, the plasma sodium is more than 145 millimole per liter. So it actually occurs as a result of inadequate concentration of the urine in the face of restricted water intake. So hypernatremia is again divided into three categories, that is hypovolemic, euvolemic, and hypervolemic, just like hyponatremia. So what happens in hypovolemic hypernatremia? In case of renal sodium loss, that is diuretic therapy, or glycosuria like in HHS, gastrointestinal sodium losses such as colonic diarrhea and excessive sweating. These are the causes of hypovolemic hypernatremia. What about the euvolemic? Diabetes insipidus, both central or nephrogenic, it causes euvolemic hypernatremia. And hypervolemic hypernatremia is when there is enteral or parenteral feeding, IV or oral salt administration, and CKD during water restriction. So again, the clinical features actually neurological, and there is actually cerebral cellular shrinkage resulting in altered mental status, irritability, weakness, focal neurological deficits, coma, death, and these patients are prone for intracerebral or subarachnoid hemorrhage. So goal of therapy is to correct the water deficit and to stop ongoing water loss. Now, how should we correct? Correction should be done over 48 to 72 hours. So it should be slow correction. If the hypernatremia is hyperacute, that is rapid development within 12 hours, correction can be rapid, and hypotonic solution like 5% dextrose or 0.45% saline or baby saline can be used. So how can we lower the sodium? It should not be lowered by 0.5 milliequivalent per liter per hour, not more than 12 milliequivalent per liter per 24 hours, just like hyponatremia. So other treatments are desmopressin and furosemide whenever it is required. So this is the formula how we can calculate the water deficit in the body. Here again, the rapid correction should never be done, as this causes cerebral edema. So these are all about the sodium imbalance. Now we move on to potassium homeostasis. So normal plasma potassium is 3.5 to 5 millimole per liter, and it is the sodium potassium ATPase pump again which maintains the body potassium level in the intracellular fluid. So kidney is the main important factors that maintain the body potassium, along with some contribution of gut, as well as there is interplay of aldosterone system that maintains the body potassium level within normal limit. Now, plasma potassium less than 3.5 millimole per liter is defined as hypokalemia, and it can be divided into mild, moderate, and severe. What do we mean by mild? It is 3 to 3.5 millimole per liter potassium, moderate is 2.5 to less than 3, and severe is less than 2.5. So how the hypokalemia occurs? Reduced intake, dietary intake of potassium will lead to hypokalemia. Then if there is redistribution of potassium from outside to inside cell, that is the potassium going inside the cell, this results in hypokalemia, excessive renal loss of potassium, as well as excessive loss through GI tract. All these four factors causes hypokalemia. So here we can see, this is the diagnostic tree, where we can see that redistribution into cells occur as a result of alkalosis, insulin excess, catecholamine beta-2 agonist, hypokalemic periodic paralysis. So what about the reduced intake? Both dietary deficiency and increased infusion of potassium-free IV fluid. Now, excessive potassium loss both by GI tract. How can we detect? Urine potassium will be less than 20 to 30 millimole per day. And from gastrointestinal tract, there may be vomiting, diarrhea, laxative abuse. These may cause potassium hypokalemia through gastrointestinal tract. Now, what about renal? In case of renal losses, the urine potassium will be more than 20 to 30 millimole per day. And if there is hypertension, we can diagnose Conn's syndrome, Cushing syndrome, glucocorticoid excess. If the blood pressure is low to normal, then they may be due to diuresis, such as loop diuretics, thiazide diuretics. Other genetic causes like Bartter syndrome, Gitelman's renal tubular acidosis should be kept in mind. So symptoms and signs in mild hypokalemia, like that is 3 to 3.5, generally people are asymptomatic, but the symptoms actually affect the neuromuscular junction. And what we see is, if the level is less than 3 millimole per liter, there will be fatigue, myalgia, lower extremity weakness, along with hypoventilation, rhabdomyolysis. Patient may come with constipation resulting in paralytic ileus. Physical examination in those patients may reveal hypotonia and hyporeflexia. Now, what about the cardiac features? There will be palpitations, as there will be arrhythmias. There may be orthostatic hypotension, decreased cardiac contractility. If patient is on digoxin, there may be arrhythmogenic potential effect of digoxin. And ECG will be abnormal. So what will be the ECG change that we will see in hypokalemia? When there is less than 2.7 millimole per liter of potassium, then we can see the ECG change. First of all, there will be change in P wave, increased amplitude and width, followed by prolonged PR interval. T wave will be flattened along with inversion. There may be ST depression, and we can see there will be prominent U waves and long QT intervals. So here is another ECG showing hypokalemia, where there is ST depression along with T wave inversion, prominent U waves, and long QU, that is QT plus U interval. With worsening hypokalemia, patient will show various arrhythmias, including atrial flutter, atrial tachycardia, VT, VF, and torsade. Here we can see in the ECG. Other investigations will include plasma bicarbonate, calcium, magnesium. If there is diagnostic dilemma, we can do plasma renin, urine chloride concentration. Therapeutic goals would be to correct potassium deficit. So it is very safe to correct potassium via oral route, and dextrose containing solution should always be avoided. So when to treat hypokalemia? In 3.5 to 4 millimole per liter, we should encourage increased intake of potassium containing food. We can see the different pictures of which we advise Dove water in almost every patient with hypokalemia, and other foods and fruit juice. And if it is 3 to 3.5 millimole per liter, only high risk patients are treated. But definitive treatment is required if it is less than 3 millimole per liter. So oral potassium should be given if the potassium level is more than 2.5 millimole per liter, and potassium chloride preparation up to 80 millimole per liter 8 hourly can be given. So the potassium should be reviewed every 3 days, and those having thiazide diuretic, we can consider potassium sparing diuretics such as spironolactone, amyloid. And we should keep in mind that hypomagnesemia may also cause hypokalemia. So we should give proper importance to correct magnesium if it is present. Now, intravenous potassium, it is a very, very important drug for the life-saving for the hypokalemia patient, and we should give it to severe symptomatic hypokalemia patient. We need continuous ECG monitoring. We should never give potassium chloride directly. We should use isotonic saline, and we should never mix it with dextrose containing solution. Of course, should not be given if the patient is oliguric. How it is given? In one ampoule, there is 10 ml of 15% potassium chloride solution containing 20 millimole of potassium. That is 1.5 gram potassium chloride. So we should start as cardiac rhythm returns to normal. It is tapered and oral potassium is initiated. In peripheral vein, we should never exceed 8 millimole per hour, and in CP line, we should never exceed 20 millimole per hour, and we should do frequent potassium checkup. Now we move on to the last, that is hyperkalemia, which is plasma potassium more than 5 millimole per liter, and it is again categorized as mild, moderate, and severe. And 5.5 to 6 is mild, moderate is 6 to 7, and severe is more than 7. So hyperkalemia diagnosis is very important because there is some spurious increase in the potassium if there is hemolysis, such as if there is difficult venipuncture, patient having clenched fist, delayed analysis, any contamination, high WBC or platelet count. So we should check whether the lab sample was given properly. Now, as I have mentioned in hypokalemia, the hyperkalemia occurs exactly opposite to hypokalemia mechanism. That is, there will be redistribution of potassium out of cells, which occurs in acidosis, insulin deficiency, beta blockers, hyperkalemic periodic paralysis, and severe hyperglycemia. Increased intake or load, such as diet, IV, or any hemolysis, rhabdomyolysis, will causes hyperkalemia. Renal retention, here gut retention is not important, only renal retention. That is, if the plasma creatinine is more than 500 micromole per liter, then we should think that there is either acute kidney injury or chronic kidney disease. But if plasma creatinine is less than 500 micromole per liter, then we should think about tubular secretory failure. If there is low aldosterone, such as in Addison's disease or adrenal enzyme defects, some drugs like NSAIDs, ACE inhibitors, we should think about it. Tubular secretory failure, such as normal to high aldosterone level, it is also important because some drugs like amyloid spironolactone may cause hyperkalemia, and some tuberointerstitial disease is important here. So clinical features is usually less than 6.5 millimole, patient is asymptomatic, but as it affects the muscle cells, there may be progressive weakness, flaccid paralysis, and hypoventilation. And in cardiac, manifestation will be arrhythmia and cardiac arrest. Often patient is asymptomatic and cardiac arrest is the first manifestation. So it is very important to find out the effects of hyperkalemia on the ECG. So if the serum potassium is more than 5.5, there will be repolarization abnormality. There will be peaked T wave, which is the earliest sign of hyperkalemia. Now, if the serum potassium is more than 6.5, there will be widening of P wave, lengthening of PR segment, and ultimately what happens is P waves eventually disappear. If serum potassium becomes more than 7 millimole per liter, there will be prolonged QRS interval, there may be high-grade AV block, sinus brady, and ultimately there will be sine wave appearance, which is a pre-terminal rhythm. If serum potassium level is more than 9, this causes cardiac arrest as a result of asystole ventricular fibrillation or pulseless electrical activity. Here I'm showing an ECG which shows broad bizarre QRS complex with tall peaked T waves. Here we can see slow junctional rhythm with peaked T waves and intraventricular conduction defect. Here we also can see in severe hyperkalemia how sine wave appearance occurred. So diagnosis is extremely important. We should exclude pseudo hyperkalemia, exclude renal failure, and we should of course stop NSAIDs and ACE inhibitors and assess potassium secretion. If it is more than 6 millimole per liter, we should treat hyperkalemia. So this is the treatment of severe hyperkalemia. IV calcium gluconate 10 ml of 10% solution over 10 minutes should be given, which stabilizes the cell membrane. Second we'll try to shift the potassium inside cells by salbutamol, that is 20 milligram in 4 ml saline, Intravenous glucose can be given neutralized with insulin, and if there is acidosis, intravenous sodium bicarbonate. Now, potassium can be removed from the body by intravenous furosemide and normal saline if there is adequate renal function. Ion exchange resin or resonium, we can give up to 25 to 50 gram 3 to 4 times a day. And finally, if it all fails, dialysis is the ultimate mode of treatment. So take-off message is volume status is extremely important in treatment of sodium imbalance, and treatment of potassium imbalance is prompt and aggressive management. Thank you. Thank you for your patient hearing.
Thank you, Dr. Abida. Thank you. So it is clear that fluid and electrolyte management actually is very important part of while managing the critical patient. So now I think we should go for the open discussion before going to that part. So I will request Dr. Tanzima Parveen to tell something about this lecture.
Assalamu alaikum. Thank you, Dr. Dhiman and Dr. Abida, for your excellent, brilliant presentation. And Dr. Dhiman told nicely about the different kinds of different categories of fluids, and which are very important for our day-to-day management of patients in CCU or ICU. And also he showed the composition of different kinds of fluid. That is also very important. And also showed the regulation of water balance. And if we don't know the regulation or pathophysiology of hypervolemia or hypovolemia, then we cannot properly manage the patient. So it is very important. Although this chapter, water and electrolyte imbalance, is known to all, but recapitulation is of these topics is very much important as we deal every day with this kind of patient. As our cardiac patient, not only having heart disease, but having diabetes mellitus, CKD, multiple comorbidities, where there is complex management is complicated management is necessary. So if we don't know the electrolyte balance and water balance properly, and we cannot manage this patient properly. And Dr. Abida has very nicely seen some slides, how we, some slides show the diagnostic flow algorithm chart, which is very important slide for our to reach a diagnosis. How we can reach diagnosis by exclusion one by one. Very much important slide. And she also told about the hyponatremia and their management, also hypokalemia. But one thing is also important, magnesium level. But when in our CCU patient management, especially arrhythmia, when we cannot correct the arrhythmia by only correction of potassium level, in that case we must look for magnesium level, because refractory arrhythmia after correction of hypokalemia is maybe due to hypomagnesemia. So magnesium level is also important in our CCU patient for managing arrhythmia, VT, in case of refractory cases. So thank you, Dr. Dhiman and Dr. Abida, for your nice presentation, and very much clearly we know about details about the management. And thank you. Thank you, organizer and chairman, madam, for giving me the opportunity as a panelist to say something in this session.
Thank you. Thank you. Now I'm requesting Professor Fazila madam to discuss about the question and answer part. Actually, I'm in the question answer chat box. Actually, I cannot see any questions, but yeah, someone actually asked about the Hartmann solution. I think to Dhiman Bonik sir, whether it is hypotonic or isotonic or hypertonic. Iman sir?
Hartmann solution is an hypertonic solution.
Okay. So, sir, please again, sir.
Is hypertonic solution.
Okay. Now the question. Now it's open discussion with, expert panelists. So, at first, I will request Professor Fazila Madam, please.
Well, first of all, I would like to congratulate both our speakers. They did a brilliant job of such a difficult subject. And I personally would request Dr. Kalimuddin to kindly upload this presentation in the YouTube so that at least we can listen. Like personally, I will need to listen to this 4 or 5 times before I totally grasp the whole content. And I think one thing is very true, that this lecture is more important for those medical officers who are managing patients in the CCO or in the ward in a day-to-day basis. Now, for examination purpose, I think some questions might be asked, especially from Abeda's lectures, like the ECGs for hyperkalemia. Very likely, if someone has an ECG of hyperkalemia, they will give it in the OSPI. So from that content, maybe it is important. Maybe short notes on diuretics might come, but I'm not sure whether these questions are more related to first part, right? Or for basic science. These questions would, like volume overload or hypernatremia, hyperkalemia, you might get questions. But for a final MD, maybe not so much, but for our own practical day-to-day care of patients, we really need to understand this very difficult subject. I still, all those formulas, all those things, lots of things to grasp. And thank you both of you for making such a difficult topic so understandable. Thank you. I really appreciate it. Great job, both of you. But I would be very happy if some of our faculty or the students would ask some questions that they didn't understand. I will need to go through this again a few times before I can ask questions. So, Professor Badiuzzzaman, do you have any comments?
Thank you, madam. Actually, I was on the way, so I missed a lot of topics. But I just listened to the last part of the topic of Dr. Abida. Actually, it, as Professor Fazila Malik has mentioned, it's a very difficult topic. And as she has mentioned, I have to go through the lecture again and again to recapitulate all those things, because management of electrolyte, especially hypokalemia, hyponatremia, hyperkalemia, hypokalemia, it's on regular basis in our CCU, ICU, and cardiology ward. I think the medical officers and the doctors who are working there, they should go through this lecture again and again to learn how to diagnose it and how to manage it. Sometimes we jump too fast to diagnose and to treat hyperkalemia or hypokalemia. So I think it was a wonderful lecture, and I have learned a lot from lecture, and I think I have to go through the lecture again and to have some knowledge. And I think, thank you very much, both the speakers. It was a very tough subject to actually give a lecture. So I think they have done a wonderful job. Thank you very much.
I'm seeing Dr. Ashok Datta, sir. Sir, Ashok Datta, sir, are you there? No. So, Professor Tuhin Haq, madam.
I'm sure একটা প্রশ্ন করি আবিদাকে। আবিদা, managing hypokalemia in our ward. You have mentioned that when we should start giving IV potassium, because I think we are in our hospital, sometimes our doctors, physicians are too hurry to give a IV potassium. So as you have seen in your presentation, we should not be so hurry. So we should wait till how long? Please, can you specify this?
Sir, if we should, when there is hypokalemia, we should start that is, if it is less than 3 millimole per liter, then we should start oral supplementation, and it is the safer alternative. So we should start the oral supplementation. Along with that, we should ask the patient to take dietary intake, but if it is less than 2.5 millimole per liter, then we should start. So the cutoff value will be less than 2.5, which is a severe hypokalemia. So then we should start intravenous potassium.
In this
What about the potassium, oral potassium? It is very corrosive and it is very irritating, gastric irritating.
Yes, sir.
So we should warn the patient before taking. It should be taken after meal, and patient should be covered with H2 blocker or PPI, because sometimes many of the patient cannot tolerate oral potassium because it is very much corrosive.
Sir, I want to add something in this aspect. That the common question is asked in the exam by the medicine teachers of our time, that how potassium you will give potassium. We should give potassium in tablet form, swallowing it, and if you give in liquid form, it should be dissolved in water, as because potassium solution of potassium causes erosive esophagitis, which is very serious, and it should be dissolved in half cup or 1 cup of water, this solution of potassium.
Okay, so we have a question. What are the common causes of SIAD? I think it's to Dr. Abida. Please unmute yourself. Abida, please unmute yourself.
Abida, unmute karo.
Abida, you need to unmute yourself. We can't hear you. Abida, unmute yourself.
Sorry. Now can you hear? Okay.
Yes.
So syndrome of inappropriate antidiuretic hormone, it's actually itself is a very broad chapter. So that's why actually I did not mention, but there are different causes of syndrome SIAD, that is, that may be tumors, any even stroke, any brain injury may cause a brain infection, may cause a SIAD. There are also commonly pulmonary pneumonia, pulmonary tuberculosis, some drugs such as opioids, then anticonvulsants. These may cause SIAD. So, and there are different diagnostic panel to actually diagnose syndrome of inappropriate antidiuretic hormone. So that is actually a different subject. So actually, that's why I did not go through.
So now that you say about pneumonia, Abida, just a thought, it came to me now. So now we are having such a lot of COVID pneumonia. So are you seeing a lot of syndrome of inappropriate ADH in these patients? I mean, most of the time we are not looking for it, but are we seeing any evidence of syndrome of inappropriate ADH in atypical pneumonia or patients with COVID pneumonia? Because we're seeing such a lot of pneumonia this last year. We've never seen this amount of pneumonia in our patients, have we? So have you seen an increase of syndrome of inappropriate ADH in your patients who had COVID or atypical pneumonia?
Actually, madam, in our CCU setting and in our COVID ward, we find quite a lot of patients with hyponatremia. So actually, whether these actually due to SIAD, so we should go through, because it is very, very important to diagnose, because the treatment is something different. So rather than infusing sodium, we should treat the patient with fluid restriction and all that. So I think actually we should try to make a study whether there is SIAD in these patients. That could be very interesting.
So yes, it will be interesting. So maybe Abida and Ishra can think about setting up protocol. So any pneumonia, atypical or COVID, we look for syndrome of inappropriate ADH. I think this will be an interesting topic to evaluate. Yes, one thing I just want to mention here about, I mean, this topic was so important for our day-to-day medical officers management. Many instances I've seen that whenever a doctor sees hyperkalemia, even if the patient is like totally all right, the ECG is totally normal, they start all the whole panel that Abida showed, the glucose, the calcium, the insulin to neutralize. But as Abida pointed, the most important cause of hyperkalemia is spurious. It is that the RBCs got disrupted somehow, and that leads. So before you treat your patient's numbers, look at the patient, see the patient, and send another potassium blood for another thing before you start treating. So this is a message to our medical officers: treat the patient whole, just don't treat the numbers. So the hyperkalemia may be spurious itself. Double check and then start your whole treatment.
Madam, I
That
can
is
see.
important for our
Actually, madam, CIAD is not so uncommon because there is new medicine marketed in by the multiple pharmaceutical companies, and many patients those we found actually hyponatremia related to diuretics and chronic kidney disease. But those patients with normal renal function, hyponatremia and hypokalemia, sometimes a few days back, I have one patient admitted with serum potassium 2.5 and sodium also 125 like. These are the group of patients hyponatremia and hypokalemia at the CR. But those patients with hyponatremia only, most likely that is either diuretics induced or related to other things actually. But CIAD is not so uncommon as we were student, because already this drug marketed and got a good popularity. So I think CIAD is not so uncommon.
I can see Professor Abim Abdul Salam sir here. Sir, do you have any comments, sir?
Thank you, Shagit Jaman. Am I audible?
Yes, sir.
Okay, I forgot to join earlier. I just see 3 or 4 slides of Dr. Abida. Probably I missed this.
একটু মাইকের কাছে যান স্যার।
বলছি যে আমি পরে জয়েন করছি, আমি যখন টের পেলাম যে এরকম একটা প্রোগ্রাম হচ্ছে, তখন আমি আবিদার মাত্র আপনার 3টা স্লাইড শুনেছি। বিষয়টা হচ্ছে যে আমরা আসলে this is a neglected part of our clinical management. Sometimes we do hurry and we don't go into the detailed electrolyte and fluid and status of the patient. This is very important for the final improvement of the patient. Sometimes some drugs do not respond. You correct this electrolyte imbalance. And particularly in cardiovascular practice, this is very important. And because all these ions and these are related with the different kind of channelopathy and as well as the cardiac function, including all details of the body. The important thing I want to mention, you have to correlate with the acid phase status along with the electrolyte. So when you are counting electrolyte problem, you have to see the acid phase status. Particularly, say for example, when there is acidosis, there might have some hyperkalemia. When there is alkalosis, there might have hypokalemia. So these are very correlated. So I think when we are diagnosing an electrolyte imbalance, you have to check the acid phase status. This is my comment. Thank you very much.
Thank you, sir. Is there any other questions? I cannot see actually.
I think there was a question from one of the audience about what is the most common cause. So we already answered that, right? Syndrome of inappropriate ADH secretion. So that was answered.
So, madam, I think now it's final words from you, madam.
But does Tuhin or Tawfiq Shariar Haq or anyone?
Actually, they are not. Tuhin, madam, is not responding.
Okay.
Tawfiq, sir.
Tuhin is there.
I'm here.
Both are there.
Okay.
I'm here, but the topic is so difficult. I'd like to congratulate both the speakers and their courage to take these difficult topics.
Very brave.
I actually I attend the lecture to learn, and I learn something, but I have to go, recapitulate and go through the subject to learn completely. So thank you and congratulations to both the speakers.
Perfect, sir.
Madam Ishaq, Madam, thank you very much. I would like to echo with Professor Fazila Malik that I need to really go through this lecture quite a few times to get a grasp of it. But I would also like to say that when we discharge our patients from our ward, in many cases we see the junior doctors overlook that two or three drugs that are causing hyperkalemia are being added to patients with pre-existing renal dysfunction. So what is when we give spironolactone with secubitril and valsartan combination nowadays, it's a very dangerous combination. Many ICM patients are being discharged with both ARNI and spironolactone, and many of these patients already has a potassium level of 5 or 4.5. So this one thing we need to be very careful. I think this I would like to say here. And thank you to Dhiman sir and Abida for their brilliant lecture and brilliant collection of data. Thank you.
Tanjima, any concluding remarks from you? Thank you for joining us. We are so grateful that you joined and gave your valuable comments. Any final comments that you would like to make?
Madam, thank you. Madam, I can keep resident, cardiology resident phase B.
Hey. There are quite a few residents I saw in the participant list. They're here. The residents are here.
কোশ্চেনটা ম্যাডাম বললেন যে ইলেকট্রোলাইট ইমব্যালেন্সের ইসিজি চেঞ্জ, এটা কিন্তু ওদের এসএকিউ কোশ্চেনের মধ্যেই আসে।
Yes, অবশ্যই।
এটা একটা শর্ট কোশ্চেন আসে 5 মার্কের। তারপরে যেমন ডায়াবেটিক রেজিস্ট্যান্স, যদিও এখানে না, তবুও এর মধ্যে চলে আসে। এটা খুব সাদের একটা কমন কোশ্চেন, হার্ট ফেলিওর ম্যানেজমেন্টের মধ্যে ডায়াবেটিক রেজিস্ট্যান্স, এই জিনিসটা সাদা খুবই প্রায় ফ্রিকোয়েন্টলি জিজ্ঞাসা করেন। আর বাকি চ্যাপ্টার তো এমনি খুবই ইম্পর্টেন্ট, হাইপোনাট্রিমিয়া, যেহেতু আমরা ড্রাগ গুলা যে কমন কিছু ড্রাগ, কার্ডিয়াক ড্রাগ ইউজ করছি, যেটাতেই এই ইলেকট্রোলাইট ইমব্যালেন্স গুলা হচ্ছে, আবার ম্যানেজমেন্ট পারপাসেও সেই কার্ডিওলজি ড্রাগ গুলাই ইউজ হচ্ছে। আবার সেজন্য ভেরি মাচ ইম্পর্টেন্ট দিস চ্যাপ্টার, এবং বিশেষ করে জুনিয়র ডক্টরের জন্য আরো বেশি ইম্পর্টেন্ট, যারা প্রতিদিন কার্ডিওলজি ওয়ার্ডে কাজ করে। থ্যাংক ইউ ম্যাডাম।
থ্যাংক ইউ আসার জন্য অনেক। আর জি প্লিজ,
অ্যানায়ন গ্যাপ, এটা আমরা আসলে কোন জায়গায় প্রয়োজন এবং এটা আমরা প্র্যাকটিস করি না তেমন একটা, কোন কোন কন্ডিশনে আপনার অ্যানায়ন গ্যাপটা দেখা দরকার?
আবিদা, অ্যানায়ন গ্যাপ কোথায় কোথায় দেখবা?
অ্যাকচুয়ালি ম্যাডাম অ্যানায়ন গ্যাপ এটা আমরা অ্যাসিডোসিস, অ্যালকালোসিস এগুলোতে মেজার করার জন্য, সো এটার জন্য আজকে ম্যাডাম এটা আমি আনি নাই।
নেক্সট টপিক, নেক্সট উইকে আমাদের অ্যানায়ন গ্যাপ নিয়ে স্পিকাররা কথা বলবে হোপফুলি, ইনশাআল্লাহ। সো নেক্সট উইকে স্যার আসবেন, আমরা will be very happy if you can join us. So Ishraq, you can say the concluding words.
Okay, thank you, madam. I think thanks to everyone who actually participates in this session. So actually we have learned a lot. As madam already told that this is very much a difficult subject, and it's important for us, especially medical officers and others, to show their to help the patients with electrolyte and fluid balance. So I think we can end here this session. So thanks to all.
Okay. And thank you.
Thank you, madam.
আসসালামু আলাইকুম।